Never ceases to amaze. Good morning, Dr. Rosensweet.
Good morning, Carolyn.
You're a little, kind of, okay. You're there, a little fuzzy, moving kind of strange.
Yeah, let me see if I can improve it. So here we are, and we're on.
We are indeed. We are indeed. And very quickly, I want to say two things that are very exciting to me. Although, it's kind of strange here. That was an excellent interview that you did with Dr. Berkson. Thank you so very, very much.
It was fun. Dr. Berkson is a deep reservoir of knowledge and experience, and it's quite a synergy we get bouncing back and forth. Absolutely, yeah.
I understand it. I do. This is a little strange here. You're very choppy, and I'm only seeing the side of your head.
Really?
Yeah. I'm wondering if I should go through the other.
Is it still the same, Carolyn? Because I see a perfect image of myself and you.
Okay, and that's fine. As a Bijou, as long as you're seeing it, then that's
and
fine.
And maybe one of our anyone who attends would comment on what they see.
Okay.
If our images look different or odd, please weigh in, folks.
Yeah, well, it's funny. What I'm seeing is probably totally different than you. My other thing that I wanted to say is that the CBHRT group and the Fate of Our Hormones in Washington just hit the 500 women and men mark. So that's huge because your link is up there. The We the Women link is up there. We have men, we have women. It's fast and furious, and it's really amazing.
That's great. And Antoinette says that she sees both of us fine.
Okay, I'm the only one
thank you,
that's not. And that's okay, because I can hear you, and it's all good.
All righty.
All righty. So here we are, and let's start with our questions. I'm going to start with the second question because this woman is really wanting some answers here. She says, good morning. I believe it's called lichen sclerosis. Oh, now you're perfectly normal. Yay. Okay, you're here. Lichen sclerosis, and she says it's extremely painful. I have no interest in sex whatsoever. It's affecting my marriage. I aggravate easily. I cry at anything. I'm a mess physically and emotionally. Something we hear often, my dear Dr. Rosensweet. Would I benefit from hormones?
Well, it sure sounds like some of what's going on for this questioner is menopausal. Oh my goodness. I don't know her age, or we didn't learn anything more about her, but as we train all of our physicians and nurse practitioners and prescribing pharmacists and PAs, when a woman of perimenopausal or menopausal age presents with a list of symptoms, sometimes long, sometimes intense, rather than doing extensive medical workups, address the hormone replenishment with expertise and see what's left. And it's remarkable. And issues of libido, issues of vaginal pain, and I'm going to get to lichen sclerosis in just a moment.
Thank you for clarifying that.
Yeah. Lichen sclerosis is, to me, and I do have experience with treating it, it's like an exaggeration of the adverse changes that can happen to the vagina when the vagina does not have adequate hormones in the body. Vaginal health, uterine health, breast health, brain health, arterial health, bone health is profoundly dependent on the ovaries and the ovarian hormones. And when the ovaries cease producing hormones, as they do, stop producing estrogens, progesterone, testosterone, and DHEA, midlife, plus or minus, all kinds of deleterious changes take place, including almost 100% to the vagina. And then to me, I'm not as deeply knowledgeable or versed in the origins of lichen sclerosis. There are definitely changes that occur in the vagina that are not the common vaginal atrophy changes that are almost universal in menopause. However, I've had success in treating women with lichen sclerosis by doing two things. One is to replenish total body hormones through topical estrogen and androgens, testosterone and DHEA, and progesterone. So bring those hormone levels back into decency through bias topically, through testosterone topically, through DHEA topically or orally, and through progesterone topically or orally. Get those numbers up there, not to youthful levels. No, we recommend, as far as estrogens go, for example, that you fall shy of youthful levels. There are exceptions to that. And then for the special recovery of the vagina, we've been successful by having the woman put testosterone and DHEA and biased directly into the vagina. Now that's going to get absorbed, and that's going to affect systemic levels. So if you download the book that Carolyn's made available, Happy Healthy Hormones on Ins and Outs of Menopause, you're going to get a lot of knowledge there, including you're going to get knowledge about what happens when you have too much estrogen, testosterone, etc. Because applying it to the vagina, that's a very absorptive surface.
Yes.
And this will not have to be done forever. In fact, in a month or two or three, you could see dramatic improvement of the lichen sclerosis and the vaginal atrophy. And if not, an ancillary visit to your gynecologist to get their knowledge, their experience, and their treatment plans for lichen sclerosis, I would think is imperative. And also, lots of things can aggravate the health of the vagina, including inappropriate acidity, insufficient acidity, infections, concurrent infections, like with yeast or even protozoa or bacteria. So when the vagina is unhealthy, you don't want to just focus totally on the diagnosis of lichen sclerosis. You want to think of, well, what could be preventing the vagina from recovery? And top of the list, loss of ovarian hormones. Top of the list, direct application of testosterone, DHEA, and estrogen intravaginally through the form of bias as far as the estrogen goes. And top of the list, if this isn't leading to rather dramatic improvement over 1, 2, 3 months, or even before, take a look at that. Have your gynecologist do an examination and an assessment of whether there's a concurrent infection there in the vagina.
Thank you, Dr. Berkson, for saying
and
that.
Dr. Berkson, yes, think about Dr. Berkson's reminding us that the intestinal tract, the gut, and the vagina, normal, healthy bacterial flora or lack of healthy bacteria flora residence. And just think about the proximity, just the physical proximity of the anus to the vagina. Cross talk, cross walk, take a
cross
little
any, yeah. When you're walking around and you know.
All, yeah. So thanks, Devaki, and good morning to you. And
yes, definitely good morning.
So all these things are to be to be considered with lichen sclerosis. And,
Yeah, this woman, she said, I feel like Freddy Krueger came in and just completely, you know, took his scissors. And oh my God, I felt just so badly for her. So I wanted to just present this question first and quickly. And it's a good answer. And so, yes, get thee to a good doctor, right?
mm-hmm.
Got it. Love you too, Dr. Berkson. Oh, yes.
Mm-hmm. Love you too, David Key.
Oh, God, my heart. So welcome to everybody who's coming up. It's so heartwarming to me. It's been a great morning. I'm really excited. I'm serious. Like 500 women, men on the, oh my God, we're going to get there to 77,000. You watch. Overnight. Here comes my second question. And this one is my own question. Because you and Dr. Berkson did discuss this. You have discussed this before. It has to do with this bruising thing. So, can we discuss what you and Dr. Berkson discussed regarding coagulability and bruising? Is this bruising that you speak of kind of like the bruising often seen on the arms of some people? You know, like those big purple.
I do.
Yeah. Okay. Well, guess who's getting them? Me. And I'm not liking it. And I see this in people, and I'm wondering, I know that there's a word called petechiae, and I guess that I'm mistaken. I don't think it's that. And you were talking about the hormones and bringing people to that like bruising point, and I'm a little confused about that. And I'm wondering, is this fixable? You know, you talk about supplements and so on and so forth, too much, too little, blah blah blah. I think you know where I'm headed with that, right?
Like how I can certainly start waxing forth.
Right.
Well, the subject of bruising has got a complexity to it. And very often we're in the realm of the whole story of functional medicine investigation of bruising, because bruising can have many origins. I mean, it's very common these days, probably more common than ever before in my career, to see bruising on elderly folks on the forearms. And so many of these folks are taking some kind of anticoagulant because they've had some kind of reason to do so, even aspirin or some of the more pharmaceutical medications that address anticoagulation, you know, very often because they've had a heart attack or a stroke.
Ugh.
And so they want to, their physician, or they're at risk for a heart attack. So what that treatment is honoring is that, you know, when you think of heart attack, you think of arteriosclerosis of the coronary arteries and blockage of the coronary arteries. And I think folks primarily imagine blockage of the coronary arteries is a matter of the arteriosclerotic plaque, the roughened surface. If you look at the surface of a coronary artery or any artery, it's smooth as silk. It's smooth as butter.
That's
like butter.
Right.
Like butter.
I can't believe it's not butter.
Like Barbara Streisand and Mike Myers and Madonna did on Saturday Night Live. If you have never seen that,
hilarious.
Look it up. Like butter. The surface of an artery. However, those arteries, and in women especially so, because estrogen confers special protection to the health of those arteries.
Right.
And as a woman loses her estrogen, she loses that protection. And the changes that can occur in a coronary artery or an artery anywhere is called arteriosclerosis. And it's a complex process, but basically what the interior of an artery of someone who has arteriosclerosis looks like, the interior that the blood is facing as it travels through these arteries, It looks like a rough surface. And any of you who have any maritime interests and you've looked at boats, when you pull them out of the water, there's these
Ooh,
things called barnacles on them.
barnacles.
You don't see the smooth painted surface of the boat that was done when once a year or however often. No, you see this rough barnacle surface. Oh my God, it's really profound how many creatures attach themselves to the bottom of a boat. Well, that's just an analogy, because our arteries that have been injured by arterial sclerosis, that's what they look like.
Right.
And the main thing about those arteries, where the danger occurs, is those roughened surfaces provoke coagulation and the formation of clots, blood clots. And when someone has a heart attack, it's not so much the atherosclerosis that's closed off the artery, which is a very slow process. No, it's the clot that formed on that artery. It's the clot in the coronary artery that is the cause of the heart attack, because that'll cut off the blood. And so the whole subject of coagulation gets more and more interesting the older we get.
Yeah.
Because arteriosclerosis, when women lose protection of the wonderful ovarian hormones, they become more vulnerable to arteriosclerosis. As I mentioned on this program before, you hardly ever hear of a woman in her 40s keeling over from a heart attack. But it's not that unusual to hear a young man in his 40s keeled over and passed away from a heart attack, never sick a day in his life. Because men are at increased risk at the earlier age than women are. Risk for men higher than the risk for women for coronary arteriosclerosis. However, by the age of 60, that risk has equalized in both men and women, and 50% of men and women leave the planet Earth because of complications of arteriosclerosis. So this is no small subject matter.
No.
And why does that incidence lower in women, younger women, than in younger men? Why does it equalize by the age of 60? Well, what's the difference? Well, the ovarian hormones are gone. So we know that estrogen confers protection. I'm mentioning that because all roads lead to Rome? No, to hormones. This rhymes with Rome.
Yeah.
Rome? All roads lead to hormones, like all roads lead to Rome. And so if there was one of a jillion reasons for a woman in perimenopause and menopause to get super interested in taking hormones, this coronary artery issue and the roughened barnacle surface that can result is a very important issue. And again, it's the clot that can be provoked on a roughened arterial surface that is the real issue.
Okay,
that's the widowmaker. That's the heart attack maker. Is the clot, because clots don't form on smooth arterial surfaces that look like butter. They form on barnacled arteriosclerotic surfaces. Now let's talk about coagulation. The coagulation mechanism, or cascade as it's called, has a zillion steps to it. Not a zillion. I don't know. I stopped counting them. There must be around 20 biochemical steps. It's so colossally sophisticated, like everything else in our human body.
I know.
What it takes to initiate a clot is step 1, step 2, step 3, step 4, step 5, and it's phenomenal. But the bottom line is, it's a very delicately balanced process, because back in the day, if we get a javelin thrown at us and it happens to land in us, we want to be able to clot to stop a hemorrhage, But if we're just walking around, we don't want to be too coagulation prone because we don't want to be clotting just walking around on our day-to-day basis. So it's a very balanced subject. Someone can be hypercoagulable. That means they have an increased propensity to clot, or they can be non-hypercoagulable and an increased propensity to bleed. So the amazing thing about the physiology of and the biochemistry of the clotting response, it is so delicately poised. So you don't have a little extra, you don't have a little not insufficiency. It's delicately poised. Except that is in theory. In actual practice, the American population is known to bend towards hypercoagulability. That means we have an increased propensity to clot. Where did that come from?
Right.
Why is that so? Well, for one thing, the coagulation mechanism is part of the Army, Navy, Marines, and Air Force that deals with germs. And people think in terms of white blood cells or gamma globulin, the many, many factors that address infection. Well, the most primitive of those factors, that's an editorial comment, I don't think it's that primitive, is you got a germ floating around in your body, your blood is going to coagulate around that germ to tie it up. Clot right on that germ. And so it's believed that one of the primary reasons that the American population is hypercoagulable, we've got an increased propensity to clot, is because the coagulation mechanism of its many functions is to tie up germs. Clot them. Throw a clot around them. They can't function so well. So hypercoagulability is an issue. And when someone comes to us in menopause and they have a history of increased propensity to clot, we want to know about that. The main reason we want to know about it back in the day was when oral estrogen was being given, because oral estrogen will increase the propensity to clot. Why in the world would someone want to take oral estrogen? When did we first find this out? When the birth control pill led to widespread prescription to women in the United States and all around the world. And some of those women were given the oral contraceptive, it's known, take it by mouth, had oral estrogen in there, oral estradiol was in there. That increased the propensity to clot. And although it was not common, there was a certain known complication to taking the oral contraceptives, and that was to get thrombophlebitis, which means you'd get a inflammation and a clot in the vein in a leg. Okay, that's lousy. But the biggest risk of those clots was they could break loose. When they're in the vein, they're called a thrombus. When they break loose, they're called an embolus, and they can travel. And
yes,
the natural path, the geography of the whole traveling through a vein is you wind up in the lung. And so there was a certain percentage of those women who did get thrombophlebitis who wound up with a pulmonary embolus. And, you know, when you see enough women in menopause and you're taking the medical history of these women, you're going to run across a woman who had a pulmonary embolus, or at least thrombophlebitis, from taking the birth control pill. Now, this is a very crucial distinction, and for anyone who is thinking of taking an oral estrogen, think twice. Go to topical estrogen, because the reputation, the science of topical estrogen is it does not promote hypercoagulation as does oral estrogen.
please hear that.
So don't be on oral estrogen. Okay, it's rare. It's rare that women who are on oral estrogen are going to get a clot, get thrombophlebitis. get a clot in their coronary arteries, but it does occur. Of course, in medicine, you never say never, even though the scientific literature states that this is a complication of oral estrogen and not a complication of topical. Wouldn't you know, 25 years of treating women in menopause, I have 2 patients that we highly suspect that even topical estrogen and progesterone led to increased coagulability. Now, ultimately, we were able to come up with a hormonal program for them that did not give them their old thrombophlebitis, because when we treated these women with hormones, Denise and Nancy, 25 years, lots of patients. Oh, I remember Denise and Nancy so well. They said, gee, I'm taking these hormones and I'm really liking them, but I'm sort of getting this ache in my leg. Like when I took the birth control pill and I had, one of them had thrombophlebitis in the lower extremity, and the other one, that progressed on to a pulmonary embolus. So you never say never, but I'll say this. When a woman has a history of thrombophlebitis or a pulmonary embolus, we start asking the question, well, what's her coagulation status right now? For example, recently I have a wonderful patient in the menopause method who had a stroke when she was young. Well, actually, she had it in her 40s, and it was believed to be caused by the birth control pill that she was put on in her 40s. Now, stroke is very, very unusual because the anatomy just doesn't allow it.
Right.
The clot would go to the lung, except for those who have a hole in the chambers of their heart, called a hole between the 2 atrial chambers, called patent foramen ovale. And those rare folks, that clot, instead of going to the lungs, it could slip through that hole and go right to the brain. That's what happened to her. So this is an example of a patient who has coagulation risk, that what we do, and this was Dr. Berkson and I were talking about, of the zillions of things we're talking about, I can't say that I remember this was specifically how we were addressing this. These women who we suspect could have enhanced coagulation, we want to assess that. And you can assess it. The 2 major laboratories in the United States have got very sophisticated coagulation profiles that can tell us. They're sophisticated because there's all those steps. So in real, I mean, you can do screening tests, but when you got someone with a coagulation issue, we want to go beyond prothrombin times,
the PT and PTNT, those,
we want to go deeper than that, and both of the major labs in the United States offer these very excellent profiles to evaluate coagulation, and we do that. There's another instance called the window of opportunity.
Thank you for bringing that up.
And what this is, if a woman is seeking treatment with hormones and she hasn't had a period for 10 years, that seems to be the magic number.
Right.
Best medicine is that woman could have developed arteriosclerosis, where if she had started right in perimenopause or early menopause with hormones, her likelihood of having arteriosclerosis is so much less that we don't go to any extreme to evaluate her coronary arteries. But when a woman has been 10 years in menopause with no hormones at all, best medicine is we evaluate her coronary arteries, because she could have developed arteriosclerosis in that time from lack of estrogen. So because heart attack is something we really care a lot about, it's those women that, number one, will do this cardiologic exam by cardiologist, or even any physician can order this test. It's called an echo stress test, and it's non-invasive, And we can see whether there's compromise to that coronary artery circulation to the heart with that test. And if there is, that means there's probably atherosclerosis there. That means we want to address this prior to necessarily launching on a major treatment program. Now, two things. One is, and Jim Hernser and I have talked about this at length, this window of opportunity was not really known to many of us until recently.
Yeah.
And we thought of all the women we treated over 25, 30 years with hormones, never thinking about this, and we never had an incident. So we're talking about something that's rare, but the reason I like to talk about these things is when you're an actual physician, you just don't want to have something adverse happen in your career.
Oh,
No, I don't want to. I mean, the prime directive in medical school is physician do no harm. And that may sound like an old saying to some people, but I can tell you, as a physician, it just matters so much to not hurt somebody. And I can think of an instance back in my career where what I didn't know did hurt somebody. And I'll tell you, that's with me to this very day.
I'm sure.
Unfortunately, there was recovery there, but what I didn't know hurt somebody. So this is yet another reason. I know I've been talking about a simple question that began with bruising and really around coagulation. And the main reason I want to give you an example is you don't have to know all these things yourself as a woman. You have one job. I've been emphasizing this from the day Carolyn and I have been started doing these Facebook Lives. You have one job as a woman. Find someone who knows what they're doing, who cares enough about treating women in menopause with compounded bioidentical hormones to have been exposed to the full knowledge base. Let them hold the knowledge. I used to work on my own cars with not such happy consequences as I rebuilt an engine on my Corvair van. It was so exciting and it was so much fun to do. And it went 7,000 miles, at which point it ground to a halt. And then when I watched someone overhaul my engine of my Volkswagen van years later, he let me hang out with him while he did it. I saw, oh, look at this. There's a million steps that I didn't know about and didn't do when I overhauled my Corvair van. Well, this mechanic did do all those steps, knew. So I no longer try and do my own auto mechanics. And
right.
So it takes us back to your job as a woman or a man. Find someone who's really cared about this subject. What I'm talking about should be common knowledge to anyone who dives in to learning about menopause and hormones. In fact, our 12-hour training program has a whole chapter on coagulation. It's for professionals, but it has a whole chapter on how do you test people. So someone who really cares about the knowledge base is going to know about these things. So you don't have to cover all these things yourself. Crazy amount of detail. Used up half of our time almost on bruising and coagulation, but it's a big topic.
It's important, I think, and go ahead.
And you can't rest on the laurels of that the increased coagulability is provoked by oral estrogen only because of those two cases I've had. So I don't rest on those laurels. But again, you don't have to know this, but what you do have to do, and this is what is so crucial for a woman in menopause, is go to a professional. You're going to have to go to a professional anyway. You cannot get these hormones, at least I don't know if that's true anymore. There's the black market. It's out there.
Yeah.
You can't get these hormones without a prescriber, which it takes a licensed healthcare practitioner, which means you're going to be working with a physician or a nurse practitioner or a physician's assistant, or in those states that allow it, a compounding pharmacist who is prescribing. That's your job. Go find the expert. Check out the menopause method. Go find the expert. That's your job. And they'll know this stuff, all these details. Now, your question was really around bruising. And that's why, and what I started off by saying is there's a lot of different causes of excessive bruising. And this is why it takes us into the realm of functional medicine. And I'm just not going to go there. But, it can be nutrient deficiency that leads to capillaries. And that's when capillaries, these tiny, tiny end stage of our arterial blood supply, when they're not healthy, they leak, and you can get bruised from that. And they can be not healthy from vitamin C deficiency. They can be unhealthy from protein deficiency. There's all kinds of things. So the petechiae, which are these microscopic ruptures of these capillaries, leading bleeding into them, and you can see the bleeding and bruising in your skin. This is a much bigger topic, and it goes beyond menopause and hormones. So when you see bruising, you're not necessarily seeing it because someone is on anticoagulants. They could be unhealthy. But the use of aspirin and all kinds of anticoagulants is the number one cause that you're going to see a bruising on people's arms or in the back of their hands. And there also can be nutritional causes and other causes. So this is in the realm of expert. Now, what Dr. Bergson and I were going to is that people who are hypercoagulable, well, sometimes you got to go so far as to get at those infections, occult viral infections, Lyme's disease, Epstein-Barr. These things exist and can be problematic. Or sometimes it's that nutritional deficiency. Or sometimes when we don't want them to be hypercoagulable, we want to protect them from a premature clot formation when they don't really need it. Well, we can thin the blood with a tremendous number of wonderful tools. I mean, you give someone enough fish oil and you're going to see bruises appear on the back of the hand of many people. Fish oil can thin that blood so much. Thin. It's not thinning of the blood. It's making it less coagulable.
Right.
Less coagulable. And that can leak right out of the capillaries and show bruises. And, as a down and dirty, so to when we don't have the ability or the financial resources to do the fancy coagulation test, and your mom's had a heart attack and your dad had a stroke, and you want to do the simple thing, take enough omega-3 supplements from fish oil, and you should be able to produce bruising. Add to that vitamin C, vitamin E, and even if you need to, some of these enzymes, lumbrokinase, it comes from earthworms. Enzymes. You should be able to take enough nutritional supplements so you get bruising on the back of your hand because you've slowed down the coagulation mechanism so much that you've tipped it over to hyperbleeding rather than hypercoagulable. You've moved it over to hyperbleeding. You're going to bleed underneath your skin. You're going to get bruises. So even this isn't terribly inexpensive, but if you have a long family history of arterial sclerosis and heart attack and stroke, you don't want to be hypercoagulable. You want to be a little on the underside, that you bleed a little too easily. And the nutritional supplements that I've said, vitamin C, vitamin E, omega-3 fatty acids, between taking enough of this stuff, which is good for you anyway, and even lumbrokinase, you should be able to get bruisy. Now, you don't want to be too bruisy, so if you take yourself to bruisy with 3 omega-3s and 6 vitamin C's and a couple of vitamin E's, you get bruisy, back off. Go down to 4. Go down to the non-bruise. You don't have to go to bruise. If you go to bruise, you can back up. Back down to your doses.
Then titration.
There's also, when we're really concerned, there's pharmaceutical medications. Some of them are injectable. Heparin, for example, this is going to prevent you from clotting.
That's how you get
And
into
there's other pharmaceutical medications that really interfere with the coagulation mechanism in someone who's hypercoagulable. Hoi, let's take a deep breath. Bruising.
big subject. I mean, I know as a kid you get a bruise, whatever, and who cared? You hit a certain age and you start getting those weird, big, ugly things because you bumped your arm on the door on the way out and it doesn't go away for 2 weeks. Something's weird about
Well, there's
that.
a couple things going on. There's fragility of the blood vessels at their tiniest phase, capillary fragility, and you can get blood leakage out of the capillaries, out of the circulatory system and into the skin, and that's what's causing the bruising. Or you can be on anticoagulants. The ones I listed, and aspirin is an effective anticoagulant. Aspirin, baby aspirin, not the kind of dose you take for a headache.
Yeah, right. Yes.
But, you can take a baby aspirin and really interfere with your coagulation mechanism. And of course, many physicians prescribe aspirin for good reason. Baby aspirin they prescribe because it's going to slow down that ability to coagulate.
Right. And so
for those who are at risk for heart attack and stroke, even if your family had one, hey, do it.
Well, the question came up, and I understand why. And she's saying, "Are you saying that fish oil is not good?" It is good.
No, I love fish oil.
Yeah.
Most of us are deficient in omega-3 fats, and fish oil is a wonderful source of that. Fish. Well, you got to find clean fish.
Exactly. You don't want the mercury. Yeah.
The Oigavault world of toxicity. But clean fish is available. I recommend salmon from Alaska. Alaska, the state of Alaska.
Oh, it's gorgeous.
Great care. They have protected their fishing industry and the salmon industry since the 1950s. Oh my God. A government agency had tremendous foresight. And we know an Alaskan fisherman, Eric, is amazing. And he was describing to me the extreme extent that the state of Alaska goes to make sure that salmon is clean and pure and available. It's wonderful. So,
whoa, Dr.
quite a source. And then there's the supplement companies, especially the ones that really care. They're getting fish oil and they're testing it for mercury, heavy metals, and other contaminants. And the stuff that they're putting into their supplements is scrutinized tremendously well.
Yeah, absolutely. Big subject. Could spend about.
Your fault, Carolyn. You asked the question.
It was my question. It was. I just honed right into you and Dr. Berkson, and I love her first name. I really want to call her by her gorgeous first name. It's a great name. Many of us just love that podcast. So that coagulability, that caught my attention big time, and I really appreciate the answer.
Of the zillions of things, I mean, Dr. Berkson is such a phenomenal expert in the world of hormones, and including the special aspect of it called the toxicity that has interfered with hormone receptor sites, among many other topics. But number one, you want to see Dr. Berkson. You want to view her because she has been on hormones, and I'm not going to reveal your age, Devaki, but it ain't young. She's not.
She's revealed it, and that's like the famous question. I asked Daryl. I was like, "How old do you think this woman is?" He was like, 48, maybe.
You want to look at her because this is how you're going to want to look when you're in your later decades. Devaki, you have to give us permission to say how old you are.
She's gorgeous.
This is walk your talk.
Absolutely.
This could be you. This could be you, women. You could have the same level of vibrant health that Dr. Bergson has given herself. So anyway,
Well, it's extremely inspirational, and I
yeah,
know that you
exactly.
played a part in that in a big way. So if we could only clone you and bring you everywhere, we'd all be very happy, I think. Moving on.
And thank you very much for that. But it's not me, it's the hormones. It's, get on a good hormone program. That's it. And stay on it for your whole life. It's, okay, the initial getting it right can take you a little while, but once you get it right, it's a piece of cake. You just keep doing the same thing year upon year, or you tweak it a little bit.
Yes.
You do it for your whole life. And what
Yeah.
an investment. What an investment in your health and well-being, and in your vagina and your libido and your energy and your hair and your face and your skin and your arteries and your bones. Oh my, muscles.
Right. And so, oh my God, the question's coming up. Boy, Gavalt is right. The question's coming up, and we will get to them. Absolutely, we will. What I'd like to ask here is question. I've always suffered anxiety and have often felt that I might have a pituitary tumor. And I asked this question because I do recall very well you're explaining to me no hormones, anxiety, what happens? Does one have to go all the way to thinking she might have a pituitary tumor due to feeling anxiety when hormones, not.
I'm a little surprised and do not see the connection at all. Zero. But between the word anxiety and a pituitary tumor,
Yeah,
I don't get it. And there's zillions of people who have small, medium, large anxiety, but I don't see any linkage whatsoever between that and a pituitary tumor. Zero.
Okay.
Now, do pituitary tumors exist? Yes, they do. In my career, I've seen one or two of them that can actually occur, but they usually present to physicians at a fairly advanced stage of where the tumor in the pituitary is causing a headache, or it's causing pressure on the optic nerve. So you're starting to get visual changes. So just because of the geography of where the pituitary gland is in relationship to the optic nerve. And they can also be picked up on earlier and more subtly before they get so big that they're a pressure issue. And by the way, most pituitary tumors, they're benign in the sense that they're not cancers. But where they're located, they cause trouble just from the size of the tumor. That's the thing. And so when they get pretty large, they're pressing on that optic nerve, or they're causing headaches. But they can be picked up before they press on the optic nerve. And you can, in cases of severe hormonal imbalance or moderate hormonal imbalance, one of the things we're doing is we're checking a couple of those pituitary hormones. And for example, if I were to see a very, very high elevated prolactin, because I'll test for that from time to time, or an unexplainably high TSH or FSH or LH, unexplainable, well, there's roads that lead us to want to visualize that pituitary with a CAT scan or an MRI. And we do that, not uncommonly. Once a year, I'm doing that. And very rarely do we turn up a pituitary tumor. Now, I am not a pituitary tumor specialist, so maybe there's some linkage between pituitary tumor and anxiety that I don't know about. And I always listen to my patients. When a patient says to me, well, I think I have a pituitary tumor, even though it doesn't make any sense whatsoever, I'll also go, okay, let's just not dismiss it. Let's just not say to him or her, oh no, you don't have a pituitary tumor.
Yeah,
You know, I
right.
keep that in the back of my mind, and maybe I'll even do a little blood test just because they mentioned it, because sometimes they've got some kind of intuition that I don't even know about. But falling shy of that rare situation, oh my, is there causes of anxiety? Let's just take on one of the most common ones. And this is more common in a woman who had the common stresses of life when she was young, but she would never say of herself, I have anxiety. Yeah, I had emotions. Yeah, I had stressful situation. But then when
Right.
I was in my 40s, I started to get this oddball anxiety. Life hadn't changed that much, but I got this weird, and I'm telling you, I got anxiety. When that happens, you want to go first to the bank where the money is, so to speak, which is low progesterone. Because as a woman starts losing her great calming hormone called progesterone, she gets anti-calming, otherwise known as nervousness, or the 20th century term anxiety. So the most common thing that happens to women who really weren't used to having anxiety, and then they get anxiety, get thee to your progesterone specialist. Or just get some over-the-counter progesterone, for God's sakes. Check that out. Especially if your periods have gotten irregular, or if you've gotten some breast tenderness, a return of PMS and stuff. Read our book, Progesterone. Now, that's not what this questioner said. This questioner sounds like this anxiety is more long-lived than just the perimenopause. So there's a lot of causes of anxiety, and it's beyond the scope of what I'm commenting on today. And there's a question that pops up that I want to take a lateral shift to.
Okay.
Karen has asked, but don't have hormones have risks? And here's the answer. No.
Thank you.
And I'm lingering on that. Now I want to elaborate on that. Lack of hormones have almost near certainty of troubles that you do not want to meet up with: bone loss, muscle loss, cognitive challenges, arterial sclerosis, on and on and on. Lack of hormones, there's almost a near certainty. It's not like, well, there's a risk. No, it's not. It's a near certainty. When those ovaries start to go, or men's testicles start to stop producing hormones, it's almost a near certainty that you're going to develop a nice long list of biological changes that you're not going to want to have. Now, is there a risk from inappropriate or excessive or unbalanced administration of hormones? Yes, there is. These are powerful biochemicals. They're the most powerful biochemicals in your body. And so our aim is don't overdose. And ultimately, if you do 24-hour urine hormone testing, did I say 24-hour urine hormone testing? I didn't say 5-point urine hormone testing. I didn't say salivary testing. I didn't say blood testing. I said 24-hour urine hormone testing. We know what the optimal ranges are, and we know what constitutes too much. So don't do too much. Now, what the public and the professional mindset for the most part is that hormones cause risk. And that was an inappropriate, that all derived, no one thought of hormones had risk very much until 2002, when the Women's Health Initiative study came out and declared a false risk. Even though in the study that was reported itself, it says there was a 1.26 increased relative risk with something called Prempro, not Premarin, that had a reduced risk in that original study. 0.79, that's less than 1. That means there's a reduced risk for women taking Premarin than from women who were not treated with Premarin, horse urine-derived estrogen, less risk. Well, there was a 1.26 relative risk for women taking Prempro, that's Premarin combined with a progestin. Talk to Phyllis Brunson about what she thinks about progestins. She's a PhD scientist who spent a career studying this stuff. Phyllis Bronson, Bronson, PhD. Please look her up if you have any question about progestins.
I guess you don't like those, huh?
However, what they reported in that Women's Health Initiative that no one heard about was the 1.26 was not statistically significant. And in science, that means it has no merit whatsoever. But no, people totally overlooked that. It was published in the original study, not statistically significant. And of course, when they followed up on these women, as they did for 18 years after they stopped that study, there was less risk even with the Prem Pro. So is there risk with hormones? Well, there's risk with faulty administration of any powerful biochemical you can name. And since hormones are so powerful, you don't want faulty administration. You want to go to someone who knows what they're doing, and they're not going to give you faulty treatment plans. They're going to give you, they're going to know their stuff, and they're going to, but you know, when you go out there, there are some faulty treatment plans out there, and I'm very uncomfortable about that because they just don't make sense and they're not healthy to me, and I'm not going to name names right now. But do hormones have increased risk? Well, we're all at risk for 1,000 diagnoses, or God knows, 5,000. And as a medical doctor, I can tell you a lot of those diagnoses are not pleasant. And for any of you who have these thousands of diagnoses, you know it up close and personal. And then, and we're all at risk for cancer. And as a male, I have a specialized increased risk for prostate cancer. And women have increased risk for breast cancer, uterine cancer, and ovarian cancer. And this is not a coincidence. There's reasons for these increased risk in these organs. So get thee to a wonderful health program so you reduce your risks, starting as young as you can think about it. But we're all at risk for cancer, and especially these gender-related cancers. However, here's the science. Women and men who are treated properly with hormones are at less risk for breast cancer, heart attack, and stroke than those who are not treated with hormones. That's the science. And for those of you who really care about the details of that, please purchase a book called Estrogen Matters by Abram Blooming and Carol Tavris. Dr. Blooming is an oncologist. That's a cancer specialist. So this is the best science we have. And so I want to answer Karen's question. Well, don't hormones have risks? Even Prem and Prempro, women who are treated with those, horse urine-derived estrogens, and this artificial molecule called progestins, they're at less risk if they're treated with Premarin and Prempro than women who are not treated.
Well, you have.
So I'd like to answer that. I never mind. I'm never concerned about answering that question over and over again, because the public and the professional public has been poisoned by false information. Doesn't mean we're not at risk. I wake up every day. I'm so grateful I'm walking and talking and thinking and having a ball. But I know it's not guaranteed. All of us probably know someone who, oh my God, they got ill and out of the blue. But we're all at risk, but we're at less risk if we're treated with hormones than if we are not.
Right, which is huge.
Oh my God, look at
No, I don't even say it. Don't say it.
Okay.
I'll say it.
Okay.
I gotta run. I got a hard stop today. Great questions came up. Dr. Rosensweet, always thank you so much. Wonderful things are happening. You're amazing. And everybody that's here is amazing. I have much gratitude. May we all have
I want to interrupt you, and I want to acknowledge you for a minute.
Aw.
This is big fun. I've been doing this a long time with you, twice a week. And your energy and your love and your caring produces a synergy that makes this whole thing fun and interesting. And so you're
Thank
the
you.
hostess with the mostest. And a tremendous support to the women in the United States. So thank you,
Thank you.
Carolyn Shapiro.
Thank you, Dr. David Rosensweet. It's a nice village, a nice family. Started one night by me in 2015. Who knew? You know, just end up, it's whatever, the universe. It's amazing. And so, with a lot of love and appreciation and gratitude, here we are. And I appreciate your taking your time to be here with me to help the women that want it and men who are now showing up nicely. So we've gone 2 minutes over, and okay.
So I'm going to sign off and bid everyone adieu until Tuesday.
Enjoy, be well, be safe, God bless. We will see everybody later. I'll see you on Tuesday.